So good morning, everybody, and welcome to this symposium on from dual to triple, advancing the integrated screening of HIV, syphilis, and hepatitis B in public health programs. My name is Kwesi Tope. I'm a professor and dean of the University of Ghana School of Public Health, and I'm also a member of the local organizing committee. And I will be moderating this session. Triple elimination, it's for us, especially in this part of the world, it's extremely important, given the challenges that we face in the integration within the health facility setting, and even in the community setting as well. And as most of you are aware, currently there's only one country in the world that technically has been able to achieve the targets for triple elimination. Who knows that country? Botswana, no. Zimbabwe, no. South Africa, no. Okay, it's outside Africa. Okay. Maldives, and a few countries. I'm sure you've heard about Botswana. Botswana moving to gold. Then Namibia has done silver for hepatitis B, and has done bronze for HIV. So you can see that it's a bit scattered. So there's a lot for us to do. Now, in terms of epidemiology, nearly 41 persons living with HIV, and we are getting more than 1 million infections every year. Now, when you look at syphilis, we have 8 million infections, cases in adults, and then 1.1 million in pregnant women. Now, if you look at hepatitis B, we normally don't talk a lot about hepatitis B, but look at the population within the Africa region, 80 million. So this is a lot. Now, for us to be able to advance this agenda, the first thing we have to do is what? Identify. And identify means we really need to diagnose the condition. Now, after you have diagnosed the condition, what do? We need to be able to implement evidence-based interventions. And finally, the interventions alone may not be able to, unless we are able to put all the different pieces together through integration. So the rationale for this symposium basically is for us to share experiences integrating the dual HIV syphilis. Is happening in a few countries, so we'll have the opportunity to share the experiences. And then moving into a new frontier. And the new frontier is looking at the triple HIV syphilis hepatitis B combo and what has been the experiences in countries that have done some work. So this is why we have this, and to help us deliver this is Dr. Andrew Mulwa from the National AIDS and STI Control Program in Kenya. He will look at the integration of the dual, and then we'll have Professor Andre Nwole from the Félix Houphouët-Boigny University in Côte d'Ivoire. He will look at the triple. So colleagues, we look forward to have a very fruitful engagement without wasting much time, because we really want to give more time so that we can engage and discuss. So I would invite the first speaker, Dr. Andrew Mulwa from the National AIDS Control Program in Kenya.
Thank you very much. It's still a morning. Good morning. Prof, in our last session, did not introduce himself at the beginning, and I had colleagues ask him to introduce himself. So I will introduce myself. My name is Dr. Andrew Mulwa, a medical doctor by profession, currently heading the National HIV and STI Control Program in the Ministry of Health in Kenya. Like has rightly been said, we actually facing triple burden of HIV, TB, not HIV, syphilis, and hepatitis. I think the HIV program, as a result of the devastating damage that the disease has done in the African continent, has actually led the programming work around the programs, and has been a major focus in a lot of the programming work. But as we countries move towards the last mile of coverage in terms of the 95-95 cascade, we realize that there are few components that must be added into the HIV programming for it to make sense or to actually have a real epidemic control. In Kenya, before 1999, HIV prevalence in the country was over 15% across the country. This in some 9 regions of the country had a prevalence of over 30%. That is before 1999. Of course, with now the intense programming in terms of testing, in terms of introduction of ARVs, continuation of treatment monitoring, we have made progress, and the national prevalence of HIV in the country is now at 3.7%, down from over 15. But still, we realize that the hepatitis prevalence in the country is comparable to the HIV prevalence now at about 3.5% or thereabout. And the syphilis is also comparable at about 3.2 or thereabout. I think I'll be able to bring out that as we continue. So it means we could be succeeding on HIV, but if we don't succeed on syphilis, we don't succeed on hepatitis, then we are not going to truly achieve the epidemic control of these 3 diseases. So I'll take you through Kenya's story about the dual testing, which is HIV syphilis. But I feel that the timing of the presentation may be a little bit off, because the current conversation is now the triple testing, onboarding of triple testing, which as a country, we have already started the protocol for evaluation and validation of the triple triple kits that are available in the market today. So I feel this is a presentation that would have made a lot of sense earlier in the year, but not now when the focus is moving to the triple kits. Thank you. Quickly, dual testing. Of course, I have outlined this. This is the outline of our presentation. Why the 3 tests, how we did it as a country, and as verifications, how we did the actual verification, and what summary of what we were able to get, and the challenges and lessons learned from the exercise. I think I had mentioned these statistics that we have a preference of 4.7%. I think these has now changed to last estimates was 3.3. Syphilis burden is 2.3%. I did not mention, for purposes of this presentation, I did not focus on hepatitis. So, of course, we realized that Kenya has been having a syphilis program, HIV program, and testing for HIV and syphilis. ANC attendance in the country is well over 90%, while the HIV testing was well over 90% as well. We realized syphilis testing, and this will, I think, will come, is here. Syphilis testing was 60%. So that means there were very many missed opportunities, and therefore combining both HIV and syphilis testing would significantly target the missed opportunities that existed in that period when we were doing single syphilis testing alone. Then, of course, there is the issue of integration, where you take one sample and clients are able to get results. Some of the syphilis testing, actually most of the time, clients would take the samples and they are told, come for your results maybe after a day or two. And that missed opportunity, that client most of the time may not be able to show up again in the clinic. Then we also, of course, have the system efficiency issues that we gain from having the two tests done together. Of course, Kenya is currently implementing a very ambitious universal health coverage program, where we have like reorganized our healthcare financing program to have a national universal health coverage program, which is being delivered by a new authority that we are calling the Social Health Authority, which has one contributory social health insurance component, has exchequer funded primary healthcare fund component, and an exchequer or tax funded emergency critical and chronic illnesses fund, which HIV, TB, malaria, on these other vertical programs that have been funded essentially by partners or donors actually are supposed to embed into our national current national health care financing landscape. I think I mentioned that we only are HIV testing before integration. We had 1.4 million women attend ANC in 2018, and of which 80% were able to get HIV testing, but only 63% were able to get syphilis testing. I think this made a case for us to combine the HIV and syphilis testing. So we also had poor reporting from the regions for syphilis, and that, of course, we were leveraging on the HIV program to improve the reporting. The issue of syphilis testing had bottlenecks, and this, of course, made a rationale for the dual testing. I think in this is the journey. I talked about this between 2012 and 2013. Kenya participated in multi-country evaluation on the generating crucial performance evidence for dual testing implementation. And in 2016, there were technical national reviews and consultations began on adoption of dual testing. In 2018, there was formal adoption of prevention of mother-to-child testing and in the HTS algorithm, where I think at the time there was only, I think it was Biolin, is it standard? I cannot remember the name. That was available, and from 2018 we started now the dual testing, and Kenya becoming the first African country to formally integrate HIV syphilis into the testing algorithm. In 2022, 2023, there was a national verification study which was conducted to change. And this was after WHO introduced a 3 testing algorithm, which countries that had achieved prevalence rates of below 5% was guided to shift to 3 testing algorithm to be able to net in more positives. And we did the verification study led by yours truly. I led the commission that did this verification in the year 2022-2023. And as a result, based on the verification study, we adopted standard Q HIV testing combo as the fastest for expectant and pregnant women. Then we got an A2, I think for our Kenya is 1 step, and fast response as the 3rd test for the country national testing algorithm. Of course, the evidence was from the multi-country evaluations. The dual testing improves workflow in terms of clients and health worker workflow in facility. Then there was also the increased uptake of syphilis testing to match the HIV testing, which I already had mentioned. And Of course, this was also aligned to our EMTCT framework 2022-2016. And currently, I already mentioned that we are developing new guidelines, and this is also aligning with now the triple testing, which I already mentioned earlier. Then I also mentioned that we were guided by the WHO guideline that guided countries to adopt 3-test algorithm. I think this is the phases which were the preparation for the verification study, and we did develop a protocol which had to go through ethical approval using the WHO genetic protocol. We adopted it to our country situation. At the time, there were only 8 candidate products that were registered in our country. So I think at the time, WHO had 22, but for those that had registered in our country were only 8. And that's why we did the 8 candidate product and requested ordered kits for the testing, selected study sites and trained staff on the study, then established a verification panel. And then the phase 2, which was the laboratory verification, we tested each candidate product with a verification panel and interpreted and analyzed the results of shared force reactivity. Then we constructed the algorithm. We also had phase 3, which was now field testing of the proposed algorithm, which we ran in parallel with the previous 2 test algorithm in the field for 2 weeks in high volume facilities and for 4 weeks in low volume facilities. And we also administered ease of use questionnaires for health workers. Then I think I already mentioned this. We talked about and the RDTs that had been registered in Kenya at the time were only 8, and 6 of them were HIV single and 2 dual tests. I think was the standard duo, standard Q and the BioLink. I think was Abbott and the Abbott kit. I think it's easier to call it that way. Was evaluated across multiple domains for clinical sensitivity, force reactivity or shared force reactivity, invalidity rate, ease of use, storage conditions and operational characteristics, pricing and supply, because our market is price sensitive, and costs of the kits was also considered. Then results of that were used to determine on construct an algorithm. In the interest of time, after our study, you can see what is in red as clinical sensitivity for BioLink Syphilis duo, which is what was 87%, while the HIV, and this was as well in the dossier at 95%. So we picked HIV syphilis, which is standard Q, as a result of the higher sensitivity of the clinical. The rest of the issues were matching, but it also had a temperature storage. Kenya has a wide range of climate, and there are areas that normal temperature is actually above 30%. So for purposes of storage, that standard Q favored our country's environment. So we adopted standard Q. I think these I have already mentioned. I don't need to go through. So this is the algorithm that we were able to construct. So for every expectant woman who visits in the a clinic for HIV testing, we start with for HIV, test for HIV, but for expectant women, there is another algorithm. This is I think the algorithm for HIV and syphilis. We start with standard Q as the first test. We also plan, because we realize that syphilis and HIV, the epidemic, the prevalence amongst the younger people is higher. So in our guidelines, we are trying to shift this not just to the expectant women, but we also focus on adolescents and young people and other key populations, female sex workers and other key populations that are affected by STIs. So capacity building of healthcare workers, of course, by the time you roll out the new algorithm, we had to build the capacity of the healthcare workers by training national TOTs, who of course trained regional TOTs or county TOTs. And now we went to the county and sub-county TOTs and training healthcare workers at their facilities. Of course, we leverage on resources from our government, development partners, and even the manufacturers of the kits also facilitated in the not just development of materials, but also in rollout of the trainings. So I think this talks about the integration required for coordination. So we have the issue of policy and evidence, which we are revising the algorithm. There was a pilot evidence for acceptability. There was policy approval, which was in the MOH guidelines. And there was also buy-in from the sub-regions or counties. Then the product, we add WHO pre-qualification, competitive pricing, demand forecasting, and KEMSA listing of the product. KEMSA is our supply chain agency for the government, and the product was also listed. Then, of course, there were financing constellations at implementation. We got funding from Global Fund, I had mentioned that, and our other development partners, PEFA included. And also, for healthcare training, we got also support from manufacturer. I think I had mentioned this. Then was integrated in the National Health Information System and supply chain readiness. Lessons, of course, we have had improved HIV syphilis testing coverage amongst pregnant and expecting women. And this, as I mentioned, we want to scale this up to cover adolescents and young people and other key populations. So in terms of streamlined clinical workflows, I think I've mentioned this at some point in the interest of time. Then the recommendations, what we have lessons learned is to ensure that we have a stable supply. Every time we shift policies, we must ensure that there is consistency in the supply chain so that we don't have breaks, that you shift and you are unable to get supply, and that we have ensured. Then we also ensure that we expand the dual testing coverage. I'm already talking about where we want to go in terms of targeting newer populations, and then strengthening digital reporting and monitoring, integrating dual testing into routine ANC and HIV testing services workflows, and continuous workflow capacity, because we need to continually build the capacity of all healthcare workers that interact with our clients. Thank you. I hope I'm in time.
So thank you very much, Dr. Mowa. Sit down and then probably get a bottle of water to cool down. This is Accra. It's very hot. I know Mombasa is hot, but Accra is also very hot. And I must say that for me, the learning point has to do with the lessons, the process, the way you gain the system efficiency, because as we move into the triple, these are the same issues that we are going to go through. So I think this will come during the question and answer. So I hope that you are writing out your questions for Dr. Mowa. He's come all the way. We don't have to let him go with no questions. So now I would invite Professor Andre Nwole. He is from Cote d'Ivoire, from the Houphouët-Boigny University, and he will talk about his work with the triple test kits.
Thank you, Prof. I just want to apologize for native speaking English, because I will make my presentation in French as the slides are in English. Alors, je voudrais d'abord remercier les organisateurs, notamment le laboratoire SD BIOSENSOR, qui me donne donc l'occasion de parler de triple élimination. Donc voilà le plan que je vais utiliser pour parler de la situation de ces 3 maladies en Côte d'Ivoire et de la riposte avant de présenter les résultats de l'évaluation du triple test que nous avons réalisé. Alors, quelle est la situation de ces 3 pathologies en Côte d'Ivoire? Alors, les dernières données, je ne sais pas si ce sont les dernières, mais en tout cas, ce sont celles que j'ai reçues du PNLS. Et je remercie donc toute l'équipe du PNLS présente dans la salle, avec à sa tête le directeur coordonnateur. En termes de 3,95, nous sommes à 85, 92 et 89. Et la transmission mère-enfant du VIH est passée en une dizaine d'années de 4% à peu près à 2%. Donc, ça n'évolue pas vite, mais ça diminue quand même. Alors, concernant, je vais passer sur ça. Concernant la syphilis, la prévalence estimée dans plusieurs documents est de 5%, même si on pense que ça doit être beaucoup moins. Et pour l'hépatite, dans les documents, c'est dit 10%, mais en réalité, les données de terrain donnent des prévalences aux alentours de 6%, entre 6 et 8%, et 6% chez la femme enceinte. Alors, la Côte d'Ivoire a assez rapidement décidé dans son plan stratégique national de lutte contre le VIH d'aller vers la double élimination, donc combiner la syphilis, la lutte contre la syphilis et le VIH en s'appuyant sur les avancées réalisées donc dans la lutte contre le VIH qui sont présentées ici. Alors, sur cette diapositive, c'est juste pour montrer que la couverture en termes de dépistage du VIH au cours des consultations prénatales est assez bonne. Et l'objectif, c'est vraiment de s'appuyer sur cette bonne couverture, entre en bleu le nombre de consultations et en rouge le nombre de dépistages réalisés. Donc, s'appuyer sur cette couverture pour aller vers l'élimination de la syphilis et de l'hépatite B en même temps que le VIH. Alors, en 2024, comme chez nos collègues du Kenya, comme l'a présenté donc le collègue du Kenya, en 2024, la Côte d'Ivoire a modifié ses algorithmes. L'algorithme de dépistage en population générale est passé à un algorithme à 3 tests. Et chez la femme enceinte, ce qui a été retenu, c'est d'utiliser le duotest de SD Bioline, donc HIV syphilis, auquel on rajoute un 3e test pour faire le dépistage de l'hépatite B. Et donc, cela en vigueur depuis 2024. Mais les supervisions réalisées par le PNLS montrent qu'il y a des difficultés dans la mise en œuvre. Et pour illustrer ces difficultés, nous avons voulu présenter les résultats Bon, ça, je peux passer. Ce sont les objectifs de la triple élimination en matière de VIH, de syphilis et d'hépatite B. Donc, vous connaissez très bien, donc je ne vais pas m'attarder là-dessus. There's a problem with this. Okay. Alors, donc, comme je disais, dans la politique stratégique du PNLS, c'est d'aller à la triple élimination, HIV, syphilis et hépatite B. Et un comité a été mis en place pour pouvoir piloter l'achèvement de cette triple élimination. Donc, je salue au passage Mme Boro qui est ici présente. Et pour cela, il faut qu'on ait de bons tests pour faire ce triple diagnostic. Et c'est dans ce cadre que nous avons évalué le triple test de SD Bioline, de BIOSENSOR, merci. Merci. Le triple test de BIOSENSOR, ouais, quand je mets SD, ça va vers ailleurs. Ouais. Voilà, donc, sur un panel de 187 échantillons, donc nous avons réalisé cette évaluation sur plasma et avec comme test de référence pour le VIH, je ne sais pas s'il y a un pointeur. Non. Donc pour le VIH, le biorad de GenScreen, pour l'hépatite B, le biorad monolisa. Et puis pour la syphilis, une combinaison d'un test de chimioluminescence, donc le maglumi. Puis, lorsque le maglumi était positif, on réalisait le TPH-AVDRL pour affiner ce diagnostic. Donc, voilà le panel qui a été utilisé. Je vais insister sur ce panel pour inviter ceux qui vont faire d'autres évaluations à inclure dans le panel des échantillons qui ont des résultats combinés. C'est-à-dire que si vous décidez de faire 100 échantillons VIH, 100 échantillons syphilis et 100 échantillons hépatite B, ne prenez pas que des mono-infections. Donc, c'est ce qui apparaît sur cette diapositive. Si on prend par exemple le cas de l'hépatite B, sur 58 échantillons, vous voyez qu'il y a 27 qui sont mono-infectés et on a une vingtaine combinés HIV, hépatite B. Et même des échantillons combinés avec la syphilis. Donc, c'est important parce que les tests qui font la triple élimination, il faut bien les évaluer dans un contexte un peu plus global pour voir si les interactions n'induisent pas des résultats un peu bizarres. Donc, voici le test de standard de SD BIOSENSOR, donc standard Q qui a été évalué. Je pense que vous avez eu l'occasion de passer sur leur site, dont vous avez vu ce test qui est en une seule cassette et donc qui permet, je pense que c'est la prochaine diapo, voilà, qui permet avec 20 microlitres d'échantillons de pouvoir en moins de 30 minutes de pouvoir avoir le résultat. Alors, quels sont les résultats que nous avons obtenus? Le tableau présente donc les résultats d'abord pour le HIV, pour l'hépatite B et la syphilis. Donc, le double tableau croisé habituel que vous connaissez. Et après, on a les performances en termes de sensibilité, spécificité. Et je saute pour aller sur la discordance. Donc, sur le VIH et l'hépatite B, on a eu de très bonnes performances, 100%. Et sur la syphilis, on a eu 4 discordances qui nous donnent environ 2%. Mais les performances sont satisfaisantes parce que pour l'hépatite, pour la syphilis, on ne s'attend pas à avoir 100 ou 99%. Ouais. Même les tests TPH-AVDRL nous donnent des performances aux alentours de 90-95%. Alors, les résultats discordants qui ont été obtenus, il y a quelques commentaires là-dessus, notamment l'échantillon faux négatif. En fait, c'est un échantillon qui était VDRL négatif, donc qui, sur le plan clinique, ne constitue des traces sérologiques, donc il n'y a pas de traitement vraiment à faire. Et sur les 3 échantillons faux positifs avec le le reste des BIOSENSOR, il y a 2 qui étaient 7 positifs sur le TPHA, mais qui ont donné des résultats négatifs en chimioluminescence. Donc, le diagnostic de la syphilis, c'est un peu délicat, donc il faut faire très attention et ne pas cataloguer systématiquement la performance du test. En termes de praticabilité, on n'a pas eu de changement de résultat au moment de la relecture. La reproductivité était bonne et il y a une bonne compatibilité aussi entre les différents supports sans total plasma et sérum. Alors, l'avantage de ce test, c'est que en une fois, on peut avoir 3 résultats avec une goutte de sang et il va permettre de régler les problèmes logistiques que nous avons actuellement en achetant un duo et un test séparé. Ce que je disais à l'équipe de SD BIOSENSOR, mais je pense qu'ils auront l'occasion de parler, c'est le coût. Aujourd'hui, on fait le diagnostic de la triple élimination avec un certain coût. Venir avec un test combiné, c'est un avantage, mais il faut qu'il soit moins cher. Voilà. Donc, nous on ne veut pas une seule partie de la solution, on veut la totale. Voilà. Donc, un seul test qui doit être encore moins cher. Donc, je pense qu'il travaille à cet effet. Et je voudrais terminer pour dire que ce test, voici les critères de performance que nous sommes fixés pour le VIH, l'hépatite B et la syphilis. Comme je disais tout à l'heure, avoir des performances à 95%, pour nous, c'est satisfaisant. Et donc, ce test peut vraiment être utilisé sur le terrain pour renforcer la triple élimination parce que dans nos pays, il y a beaucoup de problèmes logistiques. Même quand les intrants sont disponibles au niveau central, dans les formations sanitaires, il y a des problèmes de commande et les tests ne sont pas disponibles pour faire le diagnostic des populations cibles. Voilà ce que je voulais partager avec vous. Je vous remercie pour votre attention.
Okay, so, yeah. And Dr. Amua? So for those who lost their French teachers in primary school and also IT challenge, so couldn't use the short summary is that, you know, they also used to do the dual like in Kenya. And then there was that push for the triple testing for hepatitis B in addition. So they started doing it separately. They do and then adding the hepatitis. And then there were a lot of operational challenges that led to the use of the triple. And now when they started using the triple, they realized that it addressed a lot of the problems that we have. And then also above all, if you look at the sensitivity and specificity for HIV and hepatitis B, it was all 100%. Now, when you move into the syphilis, that was around, I think, 98% sensitivity and then 97.6 specificity. And this was actually comparable to the current test that we have there. So that is in summary. I'm a makeshift French teacher. So now, I think we'll open it up for questions. So I think we should have the mics around. And please, this is very important because we really have to, this is where the world is going. And we need to try and pick the lessons from those who have been able to make progress. Yes.
Thank you very much. So my question is to La Côte d'Ivoire. I wanted to speak French, but it's not working. So let me just ask in English. So right now, Ghana as well, we are doing the dual. That's HIV, syphilis, and the hepatitis. And really, when we added the syphilis to the kits, we saw a sharp rise in the tests for HIV and syphilis as well. I just wanted to find out, in doing the triple elimination testing in your country, is there 3 tests in one kit, or you still have to do 2 plus hepatitis separately? Thank you.
Okay, please give me.
Sorry.
Chris Abana from Noguchi. I'm so happy to hear about the triple test. I wanted to find out how much blood, is it whole blood or plasma? And then HIV, is it only detecting HIV 1, or it can pick both HIV 1 and 2? I don't know, or there are only 3 lines. And if it is that line for HIV, is it picking only, is it only HIV 1? Okay, thank you.
Ok, merci beaucoup. Moi, ma question s'adresse au deuxième orateur, l'orateur de la Côte d'Ivoire qui a évalué le test triple. Je pense qu'il est indéniable de constater que le fait d'avoir les 3 tests en un seul kit est un avantage. Ça permet d'avoir la complétude par rapport aux 3 tests. Parce qu'on se rend compte que les sites sur lesquels nous avons commencé, moi je suis du Bénin, où on a le test duo, syphilis et VIH à part et hépatite à part, on se rend compte que des femmes enceintes bénéficient du test duo, syphilis, VIH, et sans qu'on ne leur fasse le test hépatite. Donc, le fait que les 3 soient combinés est un avantage. Par contre, vous avez soulevé un problème.
Summarize.
Oui, yes. Il comprend très bien ce que je dis. Je voudrais que le labo puisse nous présenter l'avantage comparatif par rapport au prix. C'est un élément très essentiel qui permettra au programme vraiment de décider du choix de ces tests strips. Mais la dernière question, c'est par rapport au risque qui pourrait être lié à ce que les 3 tests soient sur une même bandelette. Si j'ai bien compris, les 3 tests sont sur la même bandelette. Est-ce qu'il n'y a pas un risque de diminution de la spécificité ou de la sensibilité de l'un ou l'autre des 3 tests qui sont combinés? Le fait que les 3 soient sur la même bandelette, est-ce que ça ne constitue pas un risque? Si oui, je voudrais que l'évaluateur puisse nous en parler. Merci.
Okay. Please, we have to keep it short and sweet. So, did you get what he said? It's a very important question that he said. I mean, the tail end is that he's asking that with the 3 tests, isn't there the risk of decreased sensitivity and specificity? That is the crux of the matter. Okay, so, Andre, you are under fire.
Thank you, Prof. Right now, you use SD Bioline as a dual test. No. You ask what you use now. So you use now SD Bioline as dual test plus a single RDT for hepatitis B. But we have the same problem with our friends there. It's difficult to get both tests together in antenatal clinical.
And the second one is whole blood or plasma?
Oui, je pense que la question, c'est est-ce que ça discrimine, si j'ai bien compris. Non, ça fait à la fois le VIH1 et le VIH2, mais ça ne discrimine pas. Comme j'allais vite, j'essaie d'insister sur le tableau qui présentait le panel d'évaluation. Si on pouvait le mettre, ça allait être bien, mais pour montrer que dans le panel, il y avait du VIH2. C'est bon, j'ai répondu à la question. La personne est quelque part là.
Yeah, Dr. Bana, did you get what he said? So he's saying that you asked about blood and plasma, and he said